Hello everyone. It's a pleasure to welcome you all to today's Young webinar organized by the Young Rheumatology Societies of Brazil and Spain. My name is Alejandro Gómez. I am a rheumatologist in Vall Hospital in Barcelona, and I will be moderating this session. Before we begin, I would like to sincerely thank all the attendees for joining us, to our excellent speakers, and the organizing teams of both societies, the JOVREUM and the Brazilian Society for Young Rheumatologists, for making this event possible. I would also like to thank the Spanish Society of Rheumatology for their technical and also moral support. And we are really excited to be here today and to present this webinar, which marks the beginning of a collaborative journey between both rheumatology societies. This is a great achievement, but it's not our final goal, because we consider this as a first step to build bridges between young rheumatologists from both regions, connecting with each other, sharing knowledge, and creating new opportunities to work together. I would like to briefly introduce JOVREUM. JOVREUM is a group of more than 130 young rheumatologists working in Spain, whose purpose is to foster and promote excellence among young professionals in the field of rheumatology and create a platform to integrate them in the Spanish Society of Rheumatology. Dr. André Ribeiro, would you like to briefly comment on who are the young members of the Sociedad Brasileña de Reumatología?
Of course. First, thank you, Alejandro, for introducing us and for helping coming up with this webinar and all of the steps that I have to go through to make it happen. So I'm André Ribeiro from Brazil. First, I'd just like to say that our president and our science chair wanted to be here, but they have some other things to do and send their apologies for really not being here. But I'll be filling in, saying some words about the Brazilian Society and the Subcomitê Jovem, which are us, Isadora and I, and many others. So our main goal is to really support young rheumatologists, increasing their access to scientific events, research activities, and initiatives promoted by our society, and really encourage participation, be that as in national subcommittees, research, or in the annual congress, to really help them develop professionally and from the scientific perspective. In addition, as we are here, we are also committed to foster collaboration with other young societies and groups worldwide, such as this webinar and some other webinars that we had with Panler. So hopefully this will be our first of many joint webinars and other collaborations between Brasil Jovem and JOVREUM.
Okay.
That's all.
Yeah, thank you, André. Yeah, definitely. In fact, we would love for as many of you as possible to get involved with us. So we are open to all your ideas and suggestions for future collaborations, whether it's educational, clinical case discussion, exchange programs, or research projects of any kind. So please don't hesitate to contact with any of us if you have any idea. So I'm going to introduce briefly this topic. It's a key area in psoriatic arthritis, which is the imaging for diagnosis and management. We have, as you can see, an excellent panel of speakers who will help us to explore the role of ultrasound and MRI in psoriatic arthritis. And we have a few housekeeping notes before we begin. This session is being recorded. If you have any questions for the speakers, please write them in the chat, and we will address them at the end of all the talks. We have one clinical case and one talk after that. And when we have finished all the four of them, we can start with the discussion. At the end of the session, a short evaluation survey will be sent to you probably tomorrow. So we will be very glad if you can fill it, because it's very helpful to us. So let's begin with the first clinical case presented by Dr. Isadora Medina from Federal University of Sao Paulo.
Thank you. Can you see my screen?
Yes.
Yes.
Okay. So good afternoon, everyone. First, I'd like to thank you for the invitation to participate in this meeting when we can discuss imaging in psoriatic arthritis. My name is Isadora Medina. I'm a rheumatologist from Federal University of São Paulo with a master's degree and postgraduate in rheumatologic ultrasound. I have no conflict of interest regarding this presentation. So ultrasound is a very useful tool in psoriatic arthritis. It can help in different scenarios, but more specific in two cases. In typical cases where patients have obvious skin disease and joint symptoms, and is necessary to understand findings with great specificity. And more challenging cases too, when musculoskeletal symptoms come first, even before skin involvement. In both cases, ultrasound can guide us to early and accurate diagnosis. So today, I will present two cases that illustrate these situations. The first case is about a 32-year-old man with past medical history of cutaneous psoriasis for 5 years, with involvement of scalp, extensor surfaces of knees, elbows, legs, and arms. His chief complaint was pain, swelling in knee for 3 months, and pain and stiffness in the ankles. Just a second. During the physical examination, I could see increased volume and temperature in the right knee and positive key signal in knee too. In ankles, he had pain or mobilization of the left ankle without palpable synovitis. Ultrasound images showed synovitis in the right knee, but showed too thickened and tense in echogenicity at the proximal patellar tendon insertion. Power Doppler signal was positive in enthesis area, consistent with a diagnosis of patellar enthesitis. Other sections showed echogenicity changes, enthesophytes, calcifications at the distal patellar tendon insertion in the knee, and another joints had synovitis in tibial-talar joint and mid-foot joints too. In this case, ultrasound helped to understand the findings and define the best treatment for this patient. Another case is about a woman, a 65-year-old woman with past medical history of metabolic syndrome, diabetes, hypertension, overweight, and osteoporosis too. She referred having had osteoarthritis of the hands for 10 years, and her chief complaints were hand pain and more stiffness over 30 minutes, progressively worsening deformity in fingers, and difficult to wear reeds. She had a positive family history for psoriatic arthritis, and during the physical examination, she had thickened fingers, enlargement and deviation of several phalanges, and no signs of skin or nail psoriasis. Ultrasound images shows osteophytes, in fact, large osteophytes at the distal interphalangeal joint, and shows enthesites in the extensor apparatus too. Hypoechogenicity, positive power Doppler in the enthesis area. Nails images shows to thickened of the nail bed, and another section shows synovites, paratendinites, enthesophytes, subcutaneous thickening, and signs of enthesites of the extensor apparatus at the proximal interphalangeal joints. Two cases, two different scenarios, two different chief complaints, but the same diagnosis, psoriatic arthritis. It was my presentation. We are available to answer later. Thank you.
Thank you very much, Dr. Isadora, for that great case, really great. So these two cases, so remember you can write down your questions in the chat and we will discuss them at the end. So now it's my pleasure to introduce Dr. André Ribeiro from Hospital de Clínicas and Hospital Moinhos de Bento, who will guide us through key imaging ultrasound findings and their clinical relevance. So please, André, go ahead.
Thank you, Alejandro. Can you see my screen well?
Yes, perfectly.
So, hello everyone, and thank you for the opportunity to be here participating in this session. I'll now quickly go over Isadora's cases and then review some of the elementary lesions we can find in PSA, to then review how to implement the ultrasound in our daily practice, and briefly discuss how to differentiate PSA from osteoarthritis in the sonographic perspective. These are my conflicts as usual. So let's start with Isadora's first case. Here, she showed us a 32-year-old man with a 5-year history of psoriasis who developed knee pain, swelling, and stiffness in both ankles. Due to a suspicion of PSA, she proceeded with a MSK ultrasound that revealed synovitis of the right knee and left ankle, in addition to some patellar enthesitis of the proximal patellar ligament with thickening, hypo, and power Doppler, confirming a diagnosis of active PSA. So in this case, it was important because sometimes small knee and ankle effusions may be missed in the physical examination. So it adds sensitivity here. And it also adds specificity here because sometimes we may misdiagnose enthesial pain as inflammatory when it's due to mechanical overload or just nociplastic pain. In her second case, the ultrasound was even more important because this is a very hard clinical scenario to differentiate inflammatory arthritis from osteoarthritis or the coexistence of both of them. So here we had a 65-year-old woman with long-standing hand OA and metabolic comorbidities who presented with progressive pain and really change of her symptoms. Due to this change, the ultrasound was done and revealed synovitis, peritonitis, and Doppler signal at the antithesis, suggesting the coexistence of PSA. So before moving to the use of ultrasound in the daily life, I think it's important to really review and understand what all of these terms refer to from the sonographic perspective. So I'll quickly go over them and then proceed to the discussion. So these terms are standardized by the OMERACT group, which has developed consensus-based definition for most of them. They are important because they homogenize how we speak and how we enroll and go on with research in addition to daily life use of ultrasound. The first one is synovitis. So synovitis is defined as the presence of synovial hypertrophy with or without Doppler signal within the joint capsule. An isolated joint effusion without the hypertrophy or the Doppler does not qualify as synovitis. On the left image, we can see grayscale thickening of the synovial tissue, in addition to some anechoic fluid at the proximal interphalangeal joint. And on the right, we can see the positive power Doppler within the synovial hypertrophy, in addition to 2 small osteophytes, which are then typical of OA. The second lesion type is enthesitis, which is one of the hallmarks of PSA and SPA in general. It's characterized by the hypoechogenicity and or thickening at the tendon insertion near the bone cortex, which may show Doppler signal if active, but also may show structural damage with erosion, enthesophyte, and calcifications. In this image, we can see the Achilles tendon inserting into the calcaneal bone. The tendon is thickened, hypoechoic. We can see some power Doppler, and we can see also structural changes like this huge calcification with some cortical irregularities. Then we have tenosynovitis, which is the thickening and hypoechogenicity of the tendon, which may also have some fluid within the synovial sheath, in addition to power Doppler around and or within the tendon, here showing the Achilles tendon. The main difference from enthesitis is how far the inflammation really is from the insertion to the bone. If it is at the insertion point, we call it enthesitis. If it is in the tendon body, we call it tenosynovitis. Peritendinitis is a more specific type of involvement in PSA, and it represents the abnormal fluid or hypoechoic tissue around the extensor tendon. Here we can see the interphalangeal joint with thickening and hypoechogenicity of the extensor tendon on top of it with some positive Doppler signal. Again, a difference from tenosynovitis to peritendinitis is that the peritendinitis is when the inflammation occurs in tendons that do not have a synovial sheath. Dactylitis represents the combination of the findings I was just showing and is the most complete form of inflammation in PSA. It is the diffuse swelling of the entire digit involving flexor tenosynovitis, enthesitis, synovitis, peritendinitis, and soft tissue edema. Here we can see the first metatarsophalangeal joint with synovitis, extensor tendon peritendinitis, and soft tissue edema with power Doppler. Lastly, erosion is defined as the discontinuity of the bone cortex, confirmed in two orthogonal planes. Here we can see the longitudinal plane with the erosion here, confirmed in the transverse plane, in addition to some synovial hypertrophy. Lastly, just one example showing a metacarpophalangeal joint with signs of activity and of chronicity, which is one of the best advantages of ultrasound. We can simultaneously assess for active inflammation, for monitoring of the disease, and also assess for structural damage. Here we can see a synovial hypertrophy with erosions and some peritendinitis associated. And then we can see the power Doppler within the tendon, within the synovial space, and within the erosion, which is a very poor prognostic factor for further damage. But so what? So we understand how the sonographic lesions are in the ultrasound perspective. The question is how this really translates to our daily practice. Well, we can use ultrasound in several moments of our practice, and I will briefly review some of them. First, as you know, the Caspar classification criteria is the one most commonly used in PSA. It relies on the combination of clinical findings, laboratory, and radiographic findings. But all of these really rely heavily on some findings that may be unspecific or that may be missed in the early disease. And this is where the ultrasound comes into place. It can detect both the entry criteria for the Caspar, meaning peripheral involvement, peripheral arthritis, and enthesitis. And it can also detect the other complementary criteria, meaning psoriatic nail dystrophy, dactylitis, and new bone formation. Due to these benefits, some studies have assessed if adding an ultrasound assessment to the classical Caspar criteria would increase its accuracy, like this study by Gang and colleagues. And in their study, they found that either adding the ultrasound or replacing the radiograph with the ultrasound increased the accuracy of the diagnosis from 89% to 93%. In this case, adding specificity to the diagnosis, as we can see in the ROC curve here in the red line that is closer to the sensitivity bar. And beyond classification, which is more intended to trials than real life, ultrasound has many applications in daily practice. First, it can be used to identify subclinical inflammation in patients with psoriasis who have musculoskeletal symptoms but not yet PSA. which may help identify early disease and really stratify these patients to decide who are the ones that need a closer follow-up or that can have a more lenient follow-up. Second, it improves diagnostic accuracy when clinical finds are equivocal. And third, in a patient that already has an established diagnosis, we can use it for follow-up, where it helps us monitor response to therapy and detect persistent inflammation. And specifically, when we are talking about how can we differentiate psoriatic arthritis versus osteoarthritis, this is a very clinically relevant question, as Isadora has just showed us, especially if her second case, because both diseases can have significant involvement of the knees, some involvement of the entasis due to the age and the metabolic syndrome that usually comes along, and involvement of the DIP joints. Ultrasound can help a lot, but unfortunately, we are not there yet for fully differentiating these two conditions. Some reviews, like this one written by Sahil Kopkar, summarize the knowledge we have thus far. This flow chart, for instance, explains how musculoskeletal ultrasound helps refine the differential diagnosis when the clinical assessment alone doesn't fully explain joint pain or swelling. When we identify enthesitis, peritendinitis, synovitis, or soft tissue edema, we move more towards a SPA diagnosis. And in contrast, when we find osteophytes, cartilage loss, small effusions in the DIP or the PIP joints, we move more toward osteoarthritis. But none of these are definite. Complementary to that algorithm, they also write about the typical findings that we may find in SPA, like involvement of the MSP, PIP, DIP, wrist, MTP5, and major entasis, in contrast to the findings we may see with osteoarthritis and CPPD, which would be more of calcifications, cartilage changes, and more structural rather than inflammatory changes. Two studies tried to differentiate these conditions. The MIDAS study is one of them, where Goldborg, Moller, and colleagues compared PSA psoriasis without arthritis and hand osteoarthritis, trying to differentiate in the distal interphalangeal joints the typical involvement of these pathologies. They performed complete clinical examination, MRI, ultrasound, and X-rays of these joints, focusing on the synovial enthesial complex, which, as you know, is a key microanatomical unit where PSA is believed to begin. Here is the cohort characteristics. It was 50 PSA patients, 12 PSO, and 13 hands away. First, all OA patients were female. PSA patients were younger than OA patients, and the PSA patients had a disease duration of 60 months. Conversely, PSA patients had more overweight than the OA patients. I am mentioning these things because all of these can influence how the elementary lesions behave in the ultrasound. So it's always important to take all of the complete clinical context into account when assessing for these pathologies. This figure shows the prevalence of sonographic findings in the DIP joint. First, when thinking about PSA, they found a numerically higher prevalence of extensor tendon enthesitis, joint, peritendinitis, and erosions. But these were, again, numerical difference, not significant ones. However, they also found, when thinking more about osteoarthritis, a higher prevalence of new bone formation, usually meaning osteophytes, but they also found a higher prevalence of grayscale changes, meaning synovial hypertrophy, and slightly more prevalence of Doppler signal in this synovial tissue, reinforcing the fact that osteoarthritis oftentimes have a reactive synovitis that may occur around the osteophytes. So these are not really that specific, and that when we think more of specific changes, we should lean towards peritendinitis, extensor tendon enthesis, and erosions. The other study was the DEUS multicenter study led by André Di Matteo, where they tried to look at enthesitis characteristics that differentiated SPA from controls, and controls were in this case osteoarthritis and fibromyalgia. And what they found, without much bigger surprises, were that the most discriminative ultrasound features for SPA were power Doppler at the enthesis and bone erosions at the enthesis, while the other is tactic structural changes such as hypo and thickening alone are not sufficient. In addition, they also found that these findings were specifically important when they were present in the Achilles enthesis or the distal patellar ligament. So to wrap it up, summarizing the key takeaways. First, ultrasound is a sensitive and specific imaging tool that helps us define both inflammatory and structural lesions and may allow for the early detection of PSA. When we combine ultrasound with clinical assessment, we can significantly improve our diagnostic accuracy and increase the specificity of the Casper criteria, for instance. However, disease specificity is limited for differentiating some pathologies, such as psoriatic arthritis from osteoarthritis. Many ultrasound findings like osteophytes, esophytes, even low-grade power Doppler can appear in OA and in patients with mechanical load. So context really matters. Recent studies like the MIDAS and DEUS have refined our understanding, showing that extensor tendon enthesitis, peritendinitis, and erosions are indeed numerically more prevalent in PSA than in OA, although it also highlighted that OA can also have some findings that may misguide us, like the synovial hypertrophy and power Doppler within that synovial hypertrophy. So in practice, what really helps us is looking for a multi-site, multi-tissue inflammatory pattern within one patient, meaning that we have to look at the distribution of joints and entities that are involved, for instance, wrists, elbows, and knees, and also look at the tissues that are involved, joints, tendons, entities, and so on and so forth, and take all of these findings interpreted in the clinical context of that patient to really come up with a diagnosis rather than relying on any single lesion. And that would be all for today. Thank you very much for your attention. And then we'll have the questions at the end. Thank you.
Yeah, thank you very much to you, André, for this great presentation. So as he said, if you have any question for Isadora or for André, please, you can type them in the chat. We all have doubts. We are all in the same boat. So I think today we have a great opportunity to make that kind of questions we always have. So please write them down, and then we will, well, our experts will try to answer them. So next, we will continue with another clinical case, which will be presented by Dr. Alicia Pérez from Hospital Santa Lucía de Cartagena, to illustrate the role of imaging in complex psoriatic arthritis scenarios. So Alicia, whenever you want.
Mm-hmm. Hello?
Yes, we can hear you and we see the presentation.
Okay. Hello, everyone. First of all, I would like to thank you for the opportunity to be here and to share this case with you. Today, I will be presenting a case report of a patient diagnosed with psoriatic arthritis, and I hope this case will highlight several key aspects of the disease. A 61-year-old man was sent to our patient clinic in 2014 due to pain and swelling, accompanied by progressive deformity affecting the small joints of both hands. Regarding his medical history, He has psoriasis since he was a child and postnatal hypoxia encephalopathy controlled with anti-epileptic drugs. No family history of any rheumatologic diseases. On admission, the patient suffered painful swelling and deformity of the hand joints persisting for more than 3 years, along with arthralgias in both knees and ankles, as well as low back pain with mixed characteristics. Psoriatic skin lesions were controlled with topical treatment. He did not report any gastrointestinal symptoms, ocular redness, or any other associated manifestation. Physical examination revealed swelling, tenderness, and structural deformities involving wrist, metacarpophalangeal, and proximal interphalangeal joints of both hands, as well as arthritis of both knees and ankles. Enthesitis, dactylitis, or psoriatic skin lesions were not present at the time of examination. We perform also baseline imaging and laboratory tests in order to characterize the patient initial presentation and to assess the extent of joint involvement. It included inflammatory markers that were slightly elevated and autoimmune panels that was all negative. We also performed some X-rays that we will see in the next slides. In this hand X-ray, we can see a generalized periarticular osteopenia, marginal bone erosions, particularly in the metacarpophalangeal and in the proximal interphalangeal joints, with joint space narrowing in those joints. We can also see that the carpal bones don't have the normal architecture, with joint space narrowing and early ankylotic changes. In the feet X-ray, we can also see that there is joint space narrowing, especially in the tarsal bones and in the metatarsophalangeal joints, with peripheral bone erosions. Subluxation of the metatarsophalangeal and periarticular osteopenia are also present. The X-ray through all the spine, besides showing degenerative changes, they show also atypical bone growth of the psoriatic arthritis, which is the parasyndesmophyte. We can see one here through the 4th vertebra to the 5th, and another one through the from the 5th through the 6th vertebra. And there is another parasyndesmophyte in the lumbar X-ray. We can see it closer. We have also the sacroiliac X-ray, which show bilateral signs of sclerosis, marginal erosions, and joint space narrowing more on the left side. Also, there is a calcification of the pubic symphysis. Considering the personal history of psoriasis and the joint involvement, this patient fulfills the classification criteria for psoriatic arthritis, as very well that explained André before. So we started methotrexate 10 milligrams per week, along with folic acid, celecoxib, and deflazacort as a painkillers. At 2 months follow-up, the patient continued to exhibit arthritis in the previously affected joints with persistently elevated inflammatory markers. Therefore, we increased methotrexate to 15 milligrams per week. During successive follow-ups between 2014 to 2019, the patient has experienced relief in pain and swelling. However, laboratory monitoring show elevated liver enzymes and hematologic abnormalities due to pharmacological causes. So we had to stop methotrexate. In 2019, the patient presented many skin and joint flares, so we decided to start a biological treatment. And considering the background of the patient and the posology, we decide to start ustekinumab every 12 weeks. From 2020 to 2025, the patient has been stabilized in terms of skin and joint manifestation with this treatment. And to conclude, psoriatic arthritis is a chronic inflammatory and autoimmune disease with skin and joint involvement, considered part of the spondyloarthritis group. It is associated with very erosive arthritis, dactylitis, or enthesitis. Our patient presented a very advanced peripheral and axial involvement at the time of examination, as we can see through the previous radiographs. Our patient responded well to methotrexate. However, it was later discontinued because of hematologic disorders. Due to his clinical manifestation and background, it was decided to start ustekinumab 90 milligrams every 12 weeks, as today is clinically controlled with it. And thank you for your attention.
Thank you very much, Alicia, for this really interesting case. So now we will present Dr. Paloma Castillo, also from Hospital Santa Lucía de Cartagena, who will present the role of MRI in psoriatic arthritis. So Paloma, please, the floor is yours whenever you want.
Thank you very much. You can see the presentation?
Yes.
Yeah, okay. Well, good afternoon to everyone. Thank you, Alejandro, for the introduction. Also, thank you to the Spanish Society and also Brazilian Society of Rheumatology for this session, okay? As mentioned, I will discuss the use of X-ray and magnetic resonance imaging, or MRI, in psoriatic arthritis. Well, I have no conflicts of interest for this session, and this is the index I will follow. Well, X-ray is the most accessible and cheap imaging technique that we can order. It is the gold standard for monitoring structural progression, but it's not useful for early diagnosis. What features do we observe in X-ray in PSA? Well, we can see bone destruction or osteolysis, peripheral erosions and bone proliferation, symmetrical joint space impingement, ankylosis, and soft tissue enlargement due to dactylitis. A very characteristic radiography finding is penicillin cap deformity. This deformity appears in patients with a very aggressive or long-standing PSA, and it translates that we should to be more aggressive with the treatment. Typically, we can see here in the proximal bone, we can see that becomes sharpened, okay, while the distal bone, the distal bone becomes hypertrophic like a cap. In these two images, we can see the pencil in the proximal bone here, and the cap in the distal one. This deformity can appear both in hands and in feet. Another particular aggressive form of PSA is the mutilant psoriatic arthritis. It is very, very severity, and it characterized by several bone destruction, digital shortening with telescoping fingers due to the redundant skin, and the characteristic penicillin cap that we see before. These changes cause a worsening or impairment in the quality of life of patient. Here we see the foot of a patient with PSA mutilans, where we can see telescoping fingers from to the second to the fifth tooth. In the X-ray, we can see osteolysis in the yellow arrow, deformity cap, pencil and cap in the red one, and also dislocation of the distal phalanges. Well, what are the differential diagnoses in the peripheral involvement of PSA? Well, as well as I comment before, I say before, in PSA, we can see predominantly affected distal interphalangeal joints. We can see ankylosis, juxta-articular bone formation, and soft tissue enlargement. Here we can see an X-ray typical of PSA with ankylosis in proximal joint, and this is the X-ray of a patient with rheumatoid arthritis with impingement of the curve. It's known, as well as we are going to see later, in both part in PSA and RA, we are going to see peripheral erosions, but here in PSA, it's going to be accompanied by proliferative bone. Well, in the differential diagnosis with erosive osteoarthritis, we can see an asymmetrical impingement of the joint space with central erosions, okay, that forming the typical gold wing, okay, in contrast with PSA, where we can see peripheral erosions combined with bone formation, creating a mouse here like Mickey Mouse. What happened with goat? Okay, in goat, we can see peripheral erosions, but it's true that these erosions are bigger. It's like a bite. Here we have a summary table about the differential diagnosis when the arthritis affects to distal interphalangeal joints. In where we can see that here in the erosive osteoarthritis, we have central erosions, okay, with marginal bone proliferation. In osteoarthritis, in psoriatic arthritis, we can see peripheral erosions with bone proliferation. And in rheumatoid arthritis, we can see marginal peripheral erosions without bone proliferation, but with juxta-articular osteopenia. Well, now I'm going to talk about axial involvement in PSA. It's true that this is a hot topic that we can see in a lot of sessions. The axial domain of PSA raises the question of whether it represents axial spondyloarthritis with psoriasis or a different clinical entity called axial psoriatic arthritis. It's true that in axial psoriatic arthritis, typically we can see affected more frequent cervical spine instead of lumbar region, and also we can see sacroiliitis or affected sacroiliac joint asymmetrically with a lumbar spine completely normal. Also, we can see parasyndesmophytes that these are a heavy and asymmetrical calcification that arise below the vertebral corner, in contrast with the syndesmophytes of the spondyloarthritis that are so fine and marginal calcification. Well, it's important to note that near 30% of patients with PSA have asymptomatic axial involvement, and more than the half of these patients experience non-inflammatory lumbar or cervical pain. Well, this is very beautiful to study, but in our daily practice, we often see patients with overlapping features of both types. Okay, here we can see in the left hand parasyndesmophytes in C4 and C5, like Alicia said before. And in the right hand, we can see a syndesmophyte, an asymmetrical fusion phase joint in a patient with spondyloarthritis. Okay, here we have another clinical case. It's a 35-year-old man diagnosed with psoriatic arthritis 4 years ago. And the domains of psoriatic arthritis affect are arthritis, dactylitis, Achilles enthesitis, psoriasis in in skin, scalp, and nails, and also she has cervical stiffness without back or cervical pain. In X-ray, we can see symmetric fusion of face joint, as well as we see before in a spondylitis, in a spondyloarthritis patient, a completely normal lumbar X-ray, and also in pelvic X-ray, we can see a sacroiliitis grade 3 and a coxarthrosis, okay, in both sides. This is typically from axial PSA. We could have sacroiliitis. This case is symmetrical, but more often are asymmetrical sacroiliitis with a completely normal lumbar spine. Well, I'm going to talk briefly about MRI. No pathognomonic findings have been described for PSA. As in spondyloarthritis, we can detect inflammatory lesions like synovitis, enthesitis, tenosynovitis, or bone marrow edema. And also we can see structural lesions like bone erosions or bone proliferation. Okay, although MRI is most commonly used for axial involvement, sometimes it's necessary to do in a peripheral joint. Here we can see in the first one, we can see synovitis. Also, we can see enthesitis and erosions. It depends on the sequence that we are going to see. It's better to see synovitis or to see erosions. In the second one, there's a MRI of an ankle where we can see an Achilles enthesitis. Well, now we're going to talk just a little about MRI with from the lumbar and sacroiliac zone. Okay, we can identify bone marrow edema, erosions, and joint fusion similar to other spondyloarthritis. Here we have a MRI of sacroiliac joint. The first one is a T1 sequence, and the second one is a T1 sequence after contrast, where we can see an active sacroiliitis in the right joint. Here we have an MRI of lumbar spine in a patient with PSA. The first one is a T1 sequence, and the second one is a STIR sequence, where we can see spondylitis at D11, D12, L1, and L2. And also we can see an inflammatory Anderson lesion in the surface end plate of L3. Well, what happened with the differential diagnosis of the axial involvement with MRI? Okay, as experts emphasize in a lot of sessions, all that glitter is not gold. It is not sacroiliitis. We could see we could see bone marrow edema or something or another hyperintensities in sacroiliitis, and it's due to another illness or it's normal in a person with postpartum, runners, or anatomical variants. Also, we can see bone marrow edema or changes in sacroiliac joints in patients with osteoitis condens ili, sacral fractures, Paget disease, hyperparathyroidism, infection, or tumor. Here we have a MRI where we can see sacral fracture. In the second one, we can see an left infection sacroiliitis, and the third one, it is an MRI, is a CT or a scan where we can see the sacroiliac, the right sacroiliac joint affected by Paget disease. Well, the first and the second images are also CT or a scan. In the first one, we can see a transverse megapophysis, or also known as Bertolotti syndrome. And the second one, we can see here an accessory sacroiliac joint. The third one is an MRI, where we can see this part, the intensity in both sacroiliac joint due to osteitis condensans ili. And in the last one, we can see changes due to osteoid osteoma. Okay, now I make a question. I would try to answer, but we can talk about this after. What images test should we order in a patient with recently diagnosis of psoriatic arthritis? Well, I think it would be a good idea to have a baseline hand and feet X-ray, also a cervical Spain, lumbar Spain, and pelvic X-ray. If we are going to start a biological therapy early, we could order for a chest X-ray and another X-ray, MRI, or scan. It's going to depend on symptomatic joints. Okay, now to conclude, I want to make 4 messages to take home. Well, the first one, X-ray continue to be essential to initial assessment and follow-up PSA patient. Cervical and lumbar spine X-ray should be ordered due to the presence of asymptomatic axial PSA. In MRI, we can observe lesions similar to other that appears in spondyloarthritis, and it is important that not all bone marrow edema is due to sacroiliitis. It's very important to make a good anamnesis, a good physical examination, and to see the proof that they have. It's very important to know what patient talk to me and what I see in the X-ray or in an MRI. So thank you very much for your attention. Excuse me for my poor English, and I will answer your questions. Thank you very much. Obrigado.
Thank you, Paloma. Your presentation was excellent and was perfect. So now we arrive to the discussion. Please feel free to write any question you have. We have several ones already, so I'm going to read them. We have 8 minutes to discuss, so it's enough, I think. One assistant asks is it useful to scan an asymptomatic tendon or joint when we suspect psoriatic arthritis, and if there are some regions that are particularly useful? This would be for Isadora and André.
Thank you, Alejandro. I'll take that one. I believe it is useful to scan for asymptomatic joints and tendons entities, as many times we can find ongoing inflammatory changes that are subclinical, and also oftentimes we find structural damage, meaning erosions in some joints and tendons where there is no pain at the moment. And I see in my practice very often that I find an erosion, then I ask the patient, like, do you have no pain here whatsoever? And then, oh yeah, I remember I had pain in this place 2 years ago. So memory can misguide us sometimes. And in addition to the places that are usually emphasized, I would always think of the joints and tendons of the wrist and hands. In addition, in the spondyloarthritis and PSA, wrist, hands, and toes. So looking there for the joints and tendons. And do not forget to look at the entices at these places too, the microentices, and the entices that showed the highest value in the Deus study were the Achilles and patellar. And in the Duet study by Grappa, they added the, again, Achilles, proximal and distal patella, and the triceps. So these were the ones that were more specific and the ones that I would say we should scan routinely.
Okay, thank you. We have another question about ultrasound. It says, what is the minimal probe frequency needed to explore extensor tendons and fasciitis in hands and distal interphalangeal synovitis?
Thank you.
Go ahead, Isadora. I was waiting for you.
Yeah.
Thank you for the question. At least 18 megahertz. In the practice, we know it's not possible sometimes, but higher frequency is better to explore these joints.
Okay, thank you. So we have a couple of questions for Paloma and Alicia. How often do you recommend repeating the X-ray, and how long after delivery can bone marrow edema still be seen on MRI?
Thank you, Alejandro, for the person who do the question. Well, it is discussed how often we have to do X-ray. Some experts recommend to do probably 2 years or 3 years, but sometimes depend of clinical of the patient. If, in my experience, if a patient is okay and she haven't got back pain or pain in hands and his arthritis is okay, I delay to make a new X-ray, but probably in an early diagnosis of PSA, I try to make the new X-ray 2 years. And in the delivery or postpartum, well, it is very discussed, okay, because of the liver cause stress in sacroiliac joint. So we know that in the first year of the baby, it is recommended not to do an MRI because we are going to see bone marrow edema because of this. Some articles start to say that we have to wait also 2 years, 18 or 25 months, sorry, to do an MRI.
Okay, thank you. So we have another question for André and Isadora. What's your approach when ultrasound findings are ambiguous? Like, for example, osteophytes and low-grade power Doppler.
Thank you for that question. It is actually an excellent and very realistic question that we see it at least a few times per month. At this moment, you really have to frame the ultrasound as like one piece of the puzzle of coming up with the diagnosis. When looking at the ultrasound, I look first I assess the location, like is it the DAP or DAP or MCP, meaning in the DAP could be both, but in the MCP, then it would be more leaning towards PSA. The distribution is only one place, 2 places, meaning 1 or 2 DAPs, or is it widespread, like 7, 8 out of the 10 DAPs are involved? If it's a more multiple sites, I would think more of PSA instead of OA. Also looking at patient phenotype, is it like 50-year-old or 70, 80-year-old? Metabolic factors like diabetes and obesity, which also leads to the formation of new osteophytes that are really huge and have reactive synovitis very often. So it's really looking at the pattern, which joints are involved, how many are involved, and then taking into account the clinical characteristics of that patient to coming up with a diagnosis. Ideally, that's how we do. Sometimes we find them, and then we have to just follow up them over time to see how they evolve.
Okay, thank you very much, André. We have one last question. If you can, any of you can answer it briefly. It says, beyond psoriatic arthritis, what conditions should be considered in the differential diagnosis when paratendonitis is observed on ultrasound?
Thank you, Juan, for the question. So these can be seen in another conditions, lupus, autoimmunity, connective tissue disease too, infections, but RRI and another spondyloarthropathies too. It depends the context, but we can see in another conditions too.
Okay, thank you all for these brilliant answers. So we came to the end of this session, and I want to thank all of the speakers and all of you, all the attendees, for participating and engaging these activities so actively. So this webinar marks the beginning of the collaboration between both societies, and we look forward to develop a lot of more initiatives together. So we are open to all your ideas. Feel free to contact with us whenever you want. And please remember to complete the evaluation survey you will receive tomorrow. So thank you again for joining us, and see you all in the next activity or the next webinar.